It's ridiculous because like what is the limit? There's 50 states and you have 60 different limits. So who's right?
But you have to have a limit, Jeff.
Yeah, but it's ridiculous. Limit based on what? Limit based on everybody lives in a state, or limit based on their individuality? I mean, they're genetically different.
Well, the opioid opponents say the higher the dose of opioid you're on, the more likely you are to die. So how could there be no limits to opioids?
That's ridiculous. So you're going to tell me somebody that's in Alabama, their genetic makeup is different than somebody who lives in New York? Well, maybe.
Well, maybe, but that's a story for another meeting, right, on pharmacogenetics. But look, there has to be some limits, so why not just choose some arbitrary number?
Yeah, well, unfortunately, that's what's happening. People are choosing arbitrary numbers, and you've got some people that are on drugs that either raise or lower the blood levels of the opiate. So how could those two patients be the same?
I agree. It's an arbitrary limit. It's been unfair to patients, and most of our colleagues, I think you'll agree, are spending their days tapering down stable patients who have been on pain medicines for years.
All right, put it here.
Good. I think abuse-deterrent formulations are helpful, at least in theory, right? We know that there's a progression of abuse, that most of the people start with oral overconsumption and then progress onto perhaps chewing or crushing the formulation, and then even onto methods like snorting or smoking or even injecting. So I think at a minimum, the newer abuse-deterrent formulation should at least halt the progression to those more dangerous routes of abuse.
Okay, so you say that it should help, but really there's no evidence that shows that it does, is there?
Well, it has to help if you think about it, right? If you make it more difficult to crush, if you make it so that it can't go into a syringe, no one's going to use it intravenously.
Okay, but you know, I mean, look what happened with Opana, for example. That was abuse-deterrent properties, and people started injecting it, getting microangiopathies, and so they didn't die from opiate abuse,
well,
they died from cardiac problems.
It never really had abuse-deterrent properties, even though you can talk about them. It wasn't labeled as such. And what are they doing injecting Opana anyway?
Well, I'll give you that. They shouldn't be injecting any of these drugs. But still, I mean, there's 4 categories, right? There's 4 categories that you have to meet criteria for abuse deterrence, and the 4th one, nobody has met.
That's right. One of the challenges we have is that there's not enough distribution of these products for us to actually study them and come up with reasonable epidemiological data of do they make a difference or not. So there's a huge controversy around the rapid onset fentanyl products, right? And the controversy comes from a medical controversy as well as some inappropriate corporate pharmaceutical practices philosophy. So they've gotten a bad name. But if you have pain that crescendos rapidly and you need a rapid onset analgesic, fentanyl is this lipid-soluble opioid that works fast. So theoretically, there should be very little difference between prescribing an IR fentanyl to an IR oxycodone or hydrocodone or morphine other than its onset time. Having said that, there's a lot of political baggage that's come along with the TRIF products. Indications only for breakthrough pain in cancer patients. Now, as clinicians, we use medicines where we see fit. We call that off-label prescribing, even though they're not specifically indicated. But the government says, hey, there's this special program, REMS, Risk Evaluation and Mitigation Strategy, where you sign away that you understand the indications. And even still, we have patients that don't have cancer that have these rapid progressions of pain who are perfect candidates for the medicine, yet we have to feel apprehensive about using them because of political and governmental issues.
Yeah, so like what would you do in a patient like that? Admit them to a hospital for the rest of their lives and put an IV in them? Right. I mean, this is a potential drug that very, very rapidly can get into the blood. I think that the other problem is that the public at large kind of confuses this, and so do politicians confuse it because we're hearing about fentanyl all over the news. But that is not prescription fentanyl. It's got the same nucleus, but they're fentanyl derivatives that are being imported from China. And so people hear fentanyl and they lump them all together and think fentanyl is the devil.
It's a bad time for fentanyl. Just last week, Massachusetts said 88 or 89% of their opioid-related deaths had fentanyl in the system. So everybody hears fentanyl and they think about our medicinal fentanyls, but it's illicit synthetic fentanyls from China and Mexico and overseas that have just invaded the drug dealers on the streets and gets into the heroin and even the cocaine and the marijuana, and we're seeing fentanyl pop up all over the place.
And you know, from a scientific perspective, a pharmacological perspective, it turns out that fentanyl, and not the illicit fentanyls, I don't even know if it's the case with the illicit fentanyls, but the pharmaceutical fentanyls, remifentanil, sufentanil, alfentanil, these drugs are amazingly clean in comparison to other opioids. In other words, they don't cause as much histamine release, you don't get as much itching, you don't get as many of the side effects that we get from typical opioids. So they're really great drugs if they're used appropriately.